So, comorbidity and differential diagnosis. Comorbidity means that you have more than one diagnosis. So you can have bipolar disorder and another diagnosis together. And in mental health in kids, it is very, very, very uncommon to see a child with only one diagnosis, right? Unless it's ADHD, maybe that one. Usually the other ones come along with comorbid diagnosis. And in bipolar disorder, the comorbid diagnoses are usually ADHD or anxiety disorder, okay? As well as behavioral disorders like conduct disorder or oppositional defiant disorder. But how do we know that these are comorbidities, right? And not that it's not bipolar, it's just that it's these illnesses, but very severe. Okay? So it's a great dilemma in kids because you will never come to that conclusion in the first hour of evaluation. So you won't, it is very uncommon that you can bring a child into an appointment and in the first hour, the psychiatrist say, yes, this is bipolar disorder. I'm completely sure, and it's nothing else that is unseen, right? Because there are lots of other things that can be occurring. When we talk about anxiety disorder, we're also talking about post-traumatic stress disorder. Now, what is the difference between comorbidity and differential diagnosis is that in differential diagnosis is we're diagnosing bipolar disorder or looking at it as bipolar disorder, but we have to consider it's not bipolar disorder, it might be post-traumatic stress disorder. It's not bipolar, it might be thyroid problems. So it's two different conditions that we're trying to tease out. Why? Because we need to treat them in a different manner. We need to use different types of medications, right? So comorbidity and differential diagnosis. Okay, so we're going to talk about some of the differential diagnosis and mix it in with how do you approach bipolar disorder in the office. When you have a kiddo, a parent or a guardian or someone that comes in and says, you know, these kiddos are having, this child is really angry, having tons of mood swings. He's really not provoked. He just, you don't know, one moment they're happy, one moment they're sad, one moment they're angry, they're breaking things, but then they hug and kiss you, and you just don't know what's going on, right? You don't know what to expect next. That's a very common comment. I don't know what mood they're going to be in. I don't know what's going to set them off. It could be something small, it could be something big, it could be nothing. And then they talk about having trouble with sleep. Not decreased need for sleep, but just having trouble with sleep. Now, what we always have to think of as psychiatrists is that it's not all mental health issues. There are other conditions that we need to make sure that we can rule out or at least identify because they will not respond to antidepressants or mood stabilizers or antipsychotics, right? And they're treated in a different manner. For example, thyroid problems. Thyroid problems are not very common in kids, right? But if you have it, it can make you present as if you have significant mood swings. And it doesn't need to be only decreased thyroid functioning like hypothyroidism, it can be hyperthyroidism. Just to give you a little bit of an idea, if a person has a thyroid problem, right, they're going to have emotional changes, usually hypothyroid, because it has to do with your metabolism. Hypothyroid slows you down. So just think about it in those terms. It slows your metabolism down. It can make you sad. It can make you have low tolerance to frustration. And anxiety can increase in either direction. Okay? You also have an increase in weight, which brings on negative self-image, right? And learning problems if you're hypothyroid. It slows your thinking down. Okay? How is it treated? You have to send them to an endocrinologist. They have to figure out why they have the thyroid problem, but you supplement with thyroid hormone. Okay? Hyperthyroidism is your metabolism is revved up. Now, if your metabolism is revved up, you're hyper, you're inattentive, you're distractible, you don't sleep very well, you're running around all over the place, right? You can be angry, you can be irritable. Boy, does that sound like a cycle, right, in bipolar disorder. So again, that has to be checked. How do you check it? It's a blood test. Their screening is a TSH, and then there are thyroid hormones like T3, T4 that you actually check. Okay? Does this mean if this is abnormal that it isn't bipolar disorder? No. You still have to continue teasing it out. But you have to treat the thyroid, okay, if it is a problem. Then we have the seizure disorder. Now, seizure disorders present in various ways. It is a no-brainer if it's a seizure disorder where they're tonic and clonic, which means they drop down to the ground and they have convulsions. Okay, it's a seizure disorder. Unless you're thinking about pseudo seizures, which is a mental health condition, right, which is they really don't have any seizure activity, but they still present with the symptoms of it. Okay, that's a whole different talk. But in a seizure disorder that you can see, it's really not that difficult to diagnose. Then you get an EEG, and if they have tonic-clonic, it's very likely that it's going to show up on the EEG. But the seizure disorders that present as bipolar disorder, or as if they had symptoms of bipolar, are in the temporal lobe. And temporal lobe seizures are very difficult to see on an EEG. You actually have to have a different electrode that usually goes up the nose and down that gets the current from the temporal lobes. So you can have a normal EEG with temporal lobe epilepsy. And temporal lobe regulates your emotions to an extent, right? So that means if you have a short circuit there, your emotions are going to be all over the place. Not only that, but people with epilepsy can have auditory, visual, but they have very commonly olfactory hallucinations. So they smell like burning rubber, and things smell bad, and no one else smells it, but they smell it, right? They can have visual changes also, like seeing blinking lights or flashing lights. That's what they would call their visual hallucinations. Tactile hallucinations also, bugs crawling on their skin, different than the hallucinations in bipolar disorder. Okay? But again, it's treated with seizure medication. For neurologists, we call them, for psychiatrists, we call them mood stabilizers, which are kind of the same to an extent. But it's very different because prognosis is different. The reaction to the type of medication they need is different. How long they need it is also different, right? You have to look for other neurological problems. But again, seizure disorders, it's not, I can't say it's very common, but it's not uncommon to find out that they have the seizure disorder, and it's not bipolar disorder. So it's very important, yes?
I'm sorry, question. You said the tonic and clonic seizure disorder, but then you said pseudo.
Yeah, there's a presentation called pseudo seizures, or non-neurological is what we call them, which is they have, the kiddos present with the movements, the tonic-clonic movements. It's more related to dissociation, to anxiety, but it's really not a seizure. So you don't treat it with seizure meds. You treat it in a different manner, with therapy and antidepressants. Well, I don't like to use the word fake because fake implies that they're doing it on purpose, and it's not necessarily purposeful. It's not necessarily on a conscious level. They can get highly anxious, and then they present something like that. But it's not a real seizure. Multiple sclerosis. Oh my gosh, that's a really tough one. Multiple sclerosis, you get diverse plaques in your brain in different areas, and they're changing. So with multiple sclerosis, there's a lot of emotional dysregulation. You can get depressed, you can become manic, there's anxiety. Because it's a neurological illness that affects different parts of your brain, they resolve, then they reappear, then they go away, then they come back again. It's ever changing. It's very uncommon, though, to have multiple sclerosis without neurological changes as well. And when I say neurological, is weakness in the extremities, muscle aches to an extent, neuropathies is what we call them. So it's not only the mood changes, but there are some clear neurological things that are happening at that point. I haven't seen an adolescent with multiple sclerosis, but it's out there. And you see it more often as a differential diagnosis in adults. Anyone else can think of any other medical condition that might look like bipolar disorder or present as... No. The other one is TBI, traumatic brain injury, and I don't have it up here, but I've already had 2 cases where there have been traumatic brain injuries because of physical abuse, that there has been some scarring in the brain. It doesn't show up as a seizure disorder, right? But the scarring is in places like the temporal lobe, which is not that common, but and so it presents also as if it were bipolar disorder. So you have to think about, yes, ma'am.
With early onset Alzheimer's or dementia present similarly?
It can, yes, actually, but it would have also neurological symptoms to it, apart from just the memory loss and the emotional dysregulation. But then even how it's not common to see those changes in children, for example. So I think that it would be very difficult we'd have to rule out so many other things before we even came to that, to a type of dementia in kids. If anything, you could think about dementia in children if there's trauma, because there can be small lesions. It depends on the trauma they've had, the physical trauma. So you can have a lot of scarring in the brain, and that could present as if it were dementia.
And the regression disorder in children?
Well, the regressive disorder in children is more developmental. And pervasive developmental disorder, and kids with autism, we'll talk about that as also a differential, not so much a differential, but a comorbidity. Because kids if you have difficulty socializing, then that's a big trigger. And we might not identify the trigger, but they might have multiple outbursts and appear as if they have mood swings, but it's not. It's really anxiety.
But are they ever comorbid? I mean,
Bipolar disorder can be comorbid with anything. We're talking more in terms of what's more common. But yes, you can have a child with autism with bipolar disorder, sure.
Fun.
Yeah. Very difficult to, but yes, you can. Okay. And that's the next thing. There it is. Anything, everything in psychiatry, in kids, right, can be the differential diagnosis also for bipolar disorder. Now we're going to kind of fly through these here. ADHD. ADHD is a dilemma for us because kids come in 4 or 5 years old, and you know that the diagnosis for ADHD, the symptoms have to be there before the age of 6, so they should be having that problem already by 4 or 5. You usually observe the symptoms or identify the symptoms once they start kindergarten because they're in a bigger group, right? And it's only one teacher now for, 50 kids? 20-something kids? So they have less structure, and you can see the symptoms more, right, with the kiddos with ADHD. Now, if you have a child with ADHD, but they're on a one-to-one with their parent at home, they're usually going to do much better unless they have severe ADHD, right? But you can basically guide a kiddo with ADHD on a one-to-one if it's mild to moderate, right? It's when you get into that social setting that the symptoms really come out, okay? But when a child has ADHD, you have to think about this. We're going to talk about ADHD that is hyperactive as well as inattentive, right? So when you have ADHD and you're a kiddo, you are caught by surprise all the time, right? Your parents say, no, I never surprise them. I forewarn them. I tell them they need to clean up their toys. They need to pick up their toys. I tell them 1 time. I tell them 2 times. I tell them 3 times. But the kiddo's inattentive, so they're really not paying attention to that until you finally raise your voice and tell them you have to pick up your toys. And all of a sudden it's, why are they mad at me? And they're deer in headlights, and they're anxious, and now it catches them by surprise. Then we're talking about anxiety at that point. And when a child is anxious, what do? They yell, they scream, they can throw things. Oh my gosh, it's bipolar disorder. They just had a mood swing. Well, there was never a mood swing. It was ADHD, and that was the whole progression of that incident. Okay? So that's one of the ways that we can misdiagnose bipolar disorder in the office, because most of our diagnosis is done based on parental observation, right, in kids, and teacher observation, other people telling us how this child is behaving and their interpretation of it. Usually when those kids come into the office, unless it's severe, they are angels, right? They're scared to death of the shot that's going to come. We don't even give shots, but they're scared to death of the shot anyway, so they're going to behave, right? Plus it's an hour, they can keep it together, it's a new environment. So as psychiatrists, you're really not going to see the behavior, again, if it's not extreme, right? So that's one way. So here we're talking about ADHD, misdiagnosing it as bipolar disorder, okay? But the other way occurs also. We can call it bipolar disorder, right? No, that's what we did. ADHD, we diagnosed this as bipolar disorder. Or it's actually ADHD, we diagnose it as ADHD, but it's actually bipolar disorder. That is the most common, okay? Why? Because they come in, they're in the classroom, they're impulsively aggressive, right? So they push the other kids. They get angry easily. They're distracted easily. They can't put their thoughts together. It's not because they're ADHD and they're distracted because of inattention. It's because their thoughts are starting to get disorganized, right? Thought disorganization is part of psychosis. Right? You can't think straight. You can't put things together. We can call it's almost like a processing issue. So they hear all this information and what they're supposed to do, but they can't put it together. They can't organize it. And so they look distracted. They look inattentive also. Okay? So they're diagnosed as ADHD. The parents identified the triggers. They're rapid cyclers, so there's just tons of triggers, and they can say, well, this makes them mad, this makes them mad, basically everything makes them mad. And then, so what's the diagnosis of ADHD? What's the treatment for ADHD? The first line treatment is stimulants. And then you add a stimulant and their ADHD is now rageful. Then, red flag, you have to think, ooh, maybe it wasn't ADHD. Maybe it is bipolar disorder. Okay? We're not even thinking of bipolar disorder. We're just calling it mood disorder again, right? Thinking bipolar disorder. So that's the dilemma. Is it right? Is it wrong? No. It's just you have to watch them. You can't diagnose necessarily in the first hour that you see a child. It's a collection of data across time. And most of these illnesses develop into something, so you can see it clearly, right? Now, when you start getting information, the first time you come in to an appointment, you get the information from the parent, and you get some of the information from the child. And we're talking younger children, pre-ads. But it's very important to get classroom information from the teacher, right? You can get psychological testing, which clarifies a lot, especially if the kiddos, when you really think about it, a 6-year-old, 7, 8-year-old doesn't have the vocabulary that an adult has to be able to identify, right? A lot of these kids are starting, when they come in to see the psychiatrist or the therapist, they've really never discussed emotions. So what does sad mean? What does angry mean? What does irritable? What does frustrated mean? They don't really know those words. They've heard them because their parents tell them all the time. You know, you're just irritable. They go, no, I'm not. What's irritable? I don't know. So you really have to go through all this vocabulary. As they build the vocabulary, then it's to our benefit because we understand better what's going on.